We'll move to a new topic, transplantation and tumor immunity. Why we need to do transplantation? Many needs required for human. Nowadays, there are type of diseases which affects mainly major organs such as kidney, liver, even lungs, heart. So they require transplantation. What is transplantation? It is implantation of non-self tissue into the body. The process of taking cells, tissues, or organs called graft or transplant from one part of individual and placing them into another, usually different individual. Donor, the individual who provides the graft. Recipient of host is the individual who receives graft. There are different types of transplantation. Broadly, we classify them as four: autograft, isograft, allograft, and xenograft. Autograft is within a same individual. Tissue or organ taken from one site and engrafted to another site in the same individual. Common one is skin grafting following bone and also following destructive injuries. Other one, isograft is identical twin. It is between graft taken from an individual and placed and another individual of the same genetic constitution. Graft made between identical twins is the main example. In the allograft, it is graft transfer between two genetically non-identical members of the same species. That's one which we do commonly for organ transplantation. It is except an identical xenografting interspecies transplantation. Autograft and isograft. Auto self, iso, genetically non-related, but same species are usually HLA match and ABO match, accepted and survive often. Allograft and xenograft are usually rejected due to genetic and antigenic incompatibility. The graft rejection. That is, rejection of the graft by the recipient is called the allograft rejection. The graft becomes vascularized during the first or 2-3 days and appears to be accepted initially. So, you mean it's a surgical procedure, 2 persons involved. Initially, HLA matching, human leukocyte antigen matching is there. We'll discuss in later in second. And also ABO blood group matching is done. Once those matched graft are there, organ is there, we initiate the transplantation. But almost it's getting a new organ or other way foreign to that particular recipient. So we need to do immunosuppression as well as making the patient in a good state, nutrition, the optimizing other disease conditions, as well as screening for cytomegalovirus, HIV, hepatitis B, C, as well as we need to do a blood culture to exclude any impending bacteremia. Likewise, we have to exclude any infection as well as inflammation in that particular recipient. So once this transplantation is done, initially the graft becomes vascularized. By about 4th day, inflammation occurs and the graft is invaded by lymphocytes and macrophages of host or recipient. Vascularity dismisses due to thrombosis and the graft undergoes ischemic necrosis if mismatch is there. By the 10th day, graft slough off if this is happening. This event result in the rejection of allograft is known as first set of response, or cell-mediated reaction is responsible for these. Rejection is primarily by the helper T cell lymphocytes, which activates cytotoxic T lymphocytes, TC cells, macrophages, and B lymphocytes. When a second allograft from the same donor is applied on a sensitized recipient in which previous graft has been rejected by the first set response, it will be rejected in accelerated fashion, like type 1 hypersensitivity. Necrosis sets in early and grafts slough off by the 6th day compared to first response. This type of rejection is known as second type response or second set response. For that, antibodies play a dominant role among which cells mediated immunity. So further, what we have to know is this mainly. That is, we would classify this rejection in mainly two ways. One is host versus graft. Then second is graft versus host. In host versus graft, again with the time sequence, we classify as hyperacute, that is immediate, and acute, that is weeks to months, or chronic, months to years. So in the hyperacute or immediate graft rejection, transplant rejection, here preform antibodies directed against the donor sites. So your patient should be sensitized by means of what I said earlier in first set response, later second set response, caused by accidental ABO blood group incompatibility. This is there. That's why we always do ABO matching. It is very rare nowadays. Present while still in the surgery with thrombosis and occlusion of graft vessels. It is associated with type 2 hypersensitivity, cytotoxic activity. But in the acute one, which takes weeks to months to develop, it is T-cell mediated immune response directed against the foreign major histocompatibility or MHC of donor graft. Inflammation and leukocyte infiltration of graft vessels leads to this graft rejection. It is the most common type. It is associated with delayed type of type 4 hypersensitivity. Chronic one, it's take, as I said earlier, months to years. It is again T-cell mediated process resulting from the foreign MHC looking like or mimicking a self MHC carrying an antigen, results in an intimal thickening and fibrosis of graft vessels as well as graft atrophy. That is associated with type 3 or 4, type 3 and 4, antigen antibody deposition as well as delayed type T-cell mediated process. That's about host versus graft. The other one is graft versus host. That is, in this case, donor T cells in the graft. That is, imagine for the kidney or liver, it may contain cells. So donor cells in the graft proliferate and attack the recipient's tissue. Most common seen in bone marrow transplant, present with diarrhea, rash, and jaundice. It is again associated with type 4 hypersensitivity. To prevent this incompatibility, what we do is, what I said, ABO matching is always done. Then tissue typing, it's termed human leukocyte antigen matching. So there are different ways of testing, but just to know HLA matching is done. It's done cross-matching. Further, as I said earlier, immunosuppression is mandatory. Immunosuppression is produced in the recipient so that the transplanted tissue survives for the longer period. We do irradiation, corticosteroid therapy, and anti-lymphocytic serum (ALS) are employed for immunosuppression in clinical transplantation. Fungal metabolites such as cyclosporin A and rapamycin are also used. They are cytotoxic drugs. They also specific T-cell inhibitory activity they show. Then transplantation anatomically protected sites, but it's not always common. There are certain privileged sites, where allografts are permitted to survive, such as cornea, cartilage, testicles. So here, lack of vascular will prevent graft rejection in corneal transplantation, which is one of common thing what we do. About graft versus host reaction, what I said earlier, you go to this, so it's common, I said, in the graft, bone marrow, lymphoid tissue. So here it's graft, it's associated with T cells in the particular graft. So they act against recipient tissues. What is about tumor immunity? Prior to that, in this particular period, once we do immunosuppression, patient is vulnerable to develop different kind of infections. In the early stage, once patient is discharged, patient is vulnerable to develop hospital-acquired infection. But time goes, due to this drastic immunosuppression, those less pathogen, we call less virulent pathogens become more prominent. such as a lot of fungi, even Aspergillus, Candida, or with some bacteria like Sphaenotropomonas, Pseudomonas, different species, Mycobacterium species likewise. Also, viruses may tend to reactivate, such as cytomegalovirus, herpes viruses, or JC, DK viruses likewise. But in here, often we do prophylaxis. We give prophylaxis. We prescribe prophylaxis, such as antimicrobial prophylaxis, specifically ganciclovir, that is antiviral for cytomegalovirus. Also, we often do not prescribe antimicrobials, but in that particular settings, if it is that particular condition is high, often we go with voriconazole for prevent uh, molds associated infections, such as Aspergillus likewise. But always clinical monitoring is very much important. We often do ask to, if patient develop fever, ask to admit as soon as possible. Then we do assessment of uh, their procalcitonin level, C-reactive protein level, even CRP, and we often do blood cultures and assess the focus and do the treatment. And it depending on the patient getting continuous or recurrent infections, we may have to optimize the immunosuppression level as well. About tumor immunity. Tumor, what is tumor? Cells that continue to replicate, fail to differentiate into specialized cells and become immortal. It broadly classified as malignant, a tumor that grows indefinitely and spreads, metastasis, also called cancer, which kills the host. Behind the other category, a tumor that is not capable of metastasis, does not kill host. Here you can see differentiated, but self-renewal, but stem cells. They produce muscle, nerve, bone, and blood. But if it is if control is gone, not under control, they go for malignant transformation and form of tumor cells. Uh, Types of cancer, carcinomas. It's mainly arising from epithelial cells, such as glands, breast, skin, lining of urogenital, digestive, and respiratory system. It's the commonest. So majority of cancers are carcinomas, while sarcomas, solid tumors of muscles, bone, and cartilage that arise from the embryological mesoderm. It is fairly less, around 2%. While leukemia, disease of the bone marrow, causing excessive production of leukocytes, around 3.5. While lymphoma, melanoma, disease that of lymph nodes and spleen that cause excessive production of lymphocytes, it's around 5.5. So just to etiology of cancer. So again, it depends on genetic vulnerabilities there, which associated with mutation, translocation, and amplification of genes. And there are environmental factors such as ultraviolet exposure, chemicals, viral infections, oncogenic transformation. So conversion of proto-oncogenes, potential for cell transformation, proto-oncogenes to oncogenes. Now cell transformation, alteration in tumor suppressor genes. These are the cofactors associated with the formation of leads to cancer. About tumor antigen. When a cell undergoes malignant transformation, it requires new surface antigens and may lose some normal antigens. A malignant tumor antigenetically different from normal tissues of the host. It is considered as allograft-like foreign and expected to induce immune response. Antigens that are present in the tumor cells but absent in the corresponding normal cell of the host are known as tumor antigens. There are two types, tumor-specific and tumor-associated antigens. The term TATA, tumor-associated transplantation antigens, and TSTA, tumor-specific transplantation antigens. In tumor-associated antigens, they are the fetal antigens and that are present in the embryonic and malignant cells, but not in the adult normal cells. So alpha fetoprotein in hepatoma and carcinoembryonic antigen in the colonic cancer. While about the immune response to the cancer, it's mainly driven by T cell mediated. Lymphokines help in the destruction of tumor cells. Human response or humoral response also beneficial, and NK cells act mainly there. Cytotoxic T cells and NK cell mediated activities therefore again for the cancer. So immunotherapy of the cancer. There are again specific and non-specific. Non-specific, we do active immunotherapy such as BCG vaccine for bladder cancers. BCG of tumor immunity enhanced macrophage cytotoxic. Levamisole is another treatment option. While specific immunotherapy, monoclonal antibodies to tumor antigens. So we provide in antibodies to inhibit antigens. Or lymphokines activated killer cells obtained by treatment of natural killer cells with interleukin used in renal carcinoma. There are some therapeutic options there. Thank you.